everyone, and welcome all to Care Not Cuff's Monthly Dispatch. Each month, we invite presenters from around the country to share their work at the intersection of mental health and mass incarceration and how they are building safer, equitable systems of care for those facing mental illness, substance use, and justice involvement. We would like to recognize and thank Rocky Mountain, sorry, sorry, my computer did something. We would like to recognize and thank Rocky Mountain Health Plan's Mental Health Colorado's elite sponsor of the year. I want to begin by acknowledging that May is Mental Health Awareness Month. This month provides an opportunity to learn about and advocate for the decriminalization of mental health and substance use conditions. Engaging with the history of mental health, mass incarceration, and their intersections provides context for the current landscape of this issue, alongside lessons from the advocates and movements that came before us as we look forward to the work that remains to be done. This evening, we are honored to have historian Ann Parsons, Associate Professor and Director of Public History at the University of North Carolina at Greensboro, author of From Asylum to Prison, Deinstitutionalization and the Rise of Mass Incarceration After 1945, and curator of the National Library of Medicine's new traveling exhibit, Care and Custody, A History of Mental Health. Tonight, we will start with the presentation, followed by a discussion. During the presentation portion, we kindly ask that you please stay muted. And with that, I will turn it over to Ann.
Thank you. Hello, everyone. Michaela, if you're able to if anything goes awry at any point, just let me know, just with slides or my audio or whatnot. Hi, everyone. It's a pleasure to be here and an honor to be part of this this group that's doing so much work around decriminalizing mental health, which is just so important today. I'm a public historian, which means I'm a historian who's most interested in taking history out to museums and historic sites to the general public and having it inform our decisions today. I studied the history of mental hospitals in the 20th century, particularly in Pennsylvania, and with that have published a book, From Asylum to Prison, which came out a few years ago. I also curate exhibitions, including on LGBTQ history, Black history, history of disability, social medicine, really trying to take often marginalized topics and bring them into the public sphere. Right now, I'm actually working on an exhibit, Roots of Resistance, the Tuchin story, which is about an uprising in Western Ukraine during the Holocaust. And so that's what I'm up to these days. What we'll do is really look at some moments in the history of mental health care in the 19th and 20th centuries. There's no way to do it all. So the idea is to be looking at some highlights from the exhibit, some pieces, and then really having a discussion about it, a pretty robust discussion for about 20 minutes at the end. My approach in a lot of what I do is that historians are not the be-all, end-all experts. And if anything, I've really learned that in doing the history of mental health. For me, the way I approach this work is that I'm often doing work in archives, in materials of people who have come before us, whether decades or centuries before, and then I bring that to the public and then have discussions and dialogues. So what I hope to do this evening is create a mini learning community for the hour where we can learn some of this material and discuss it together. So with that, I actually had just a brief question prompt, if you feel comfortable answering, just what drew you to this talk this evening. And here I was going to ask if you can just respond in the chat, just so I can get a sense of what got people to come out on a Thursday night at 5. And again, I'm appreciative, but that helps us, learn about who's in the room. Suggested by your supervisor. Thank you for coming. I appreciate that when it's tied to work and after hours. Learning more about the systems we work within and like how that developed, and then trying to understand those roots and helping people navigate them that's powerful. Thank you. If anyone else feels comfortable, I have a graduate student getting a master's in social work for public policy. Thank you for coming. Also, and an emergency medical physician who's that are thinking about this as part of the challenge. Thank you for coming out of your personal interests and professional interests, learning new perspectives, and thinking about this history. One thing that resonates with me is that people are coming often tied to work or personal interests, and also this concept that the history, what's happened in the past beyond just the last 10 years is actually shaping, someone says it's shaping our present, and that's so true. A lot of what has been built up creates the systems in which we're working, and so understanding how those are built up often can help us understand better the levers of how to then make change. Does that make sense? Like what could be taken apart or what could be made better or stronger? So thank you. I also appreciate the history geek. And um, and yeah, that concept that there's a historical pendulum that's swinging back and forth between community and restrictive environments. You can see why I approach these talks very much as a learning community, because I feel I bring my perspective, but all of you are bringing a wide variety of perspectives, and I really hope that comes out in the discussion as we hear from you what's going on. Thank you. I'll say for me, what drew me, on a personal note, this exhibit launched in 2023, and at the very moment that it launched, it started traveling nationally. At the very moment it launched, we suddenly had a serious case of leukemia in my immediate family, and so this is actually my first main public talk about this. I was so excited and honored to be speaking with a group that's doing work around decriminalizing mental health. Like that resonated with me. And so for me, it's a particular pleasure that this is my first group. So that's what led me to this talk today. I'm glad to be in this stage. Now let me just minimize this for a minute so I can see some of my slides as I begin. So the exhibit Care and Custody, as was mentioned, was produced by the NIH's National Library of Medicine. And there's a photograph of me with a student in front of the exhibit. There are 3 banners and of 6 total standing banners that are traveling around the country to about 20 locations this year. It's going to keep traveling next year to another 20 locations. Right now, there are 2 copies, one in Indianapolis and one in Columbus. The exhibit also has an online exhibition with a lot of images and documents. So if you look up NLM Care and Custody or National Library of Medicine Care and Custody, that will come up pretty immediately, and you can explore the digital galleries. Brought up slides that show the National Library of Medicine, a very large building on the Bethesda campus in Bethesda, Maryland of NIH. A lot of my process was doing research in their archives on the NIH campus, and the images that I'm sharing today are pretty much all from the National Library of Medicine. The exhibit was curated from 2017 to 2019, and it was going to launch in 2020, but it was delayed due to the pandemic. Just a side note, if anyone wants to bring the exhibit to their community, it's for free. I think the only cost is shipping, which is like a few $100s, but it's free to bring it to your community. So if you'd like to bring it to start conversations, you're welcome to. The big idea of the exhibit was that often when we talk about mental health, we don't think about the criminal legal system. We are not talking about prisons and jails in the history of mental health. Historians aren't. For me, I had done work in criminal justice reform, and I found that in the real world, actually mental health was completely a part of the criminal legal system, and that was a huge issue. And so a big idea of this exhibit and my work has been that for decades and indeed centuries in the United States, there has been a constant tension between providing care and custody in mental health policies. I asked the audiences to really consider a few questions as they explored the exhibit. One was how society has moved away from custodial forms of treatment for people with mental health conditions, how people have sought a more inclusive society, and how people have worked to protect the rights of individuals with mental health conditions. For me, my sense is that Mental Health Colorado is really trying to move the needle on these issues, and it's something that I'm trying to teach broader audiences about the work that people are doing to really create more inclusivity, to establish more rights, and to be thoughtful about the use of custody. The exhibit begins in the 19th century. Before states built asylums, local communities in the 1800s often provided piecemeal care for people diagnosed as insane. So often people were placed in jails or poorhouses, often behind bars. And so in the mid-1800s, there was a reform movement, of which Dorothea Dix is often the most well-known, to create asylums that were specifically spaces that were intended to care for people. Asylums developed as a response to people being behind bars. It's kind of the irony now. Asylums became so custodial, but when they first emerged, reformers were trying to address mental health in a way that was not in jails and that was not keeping people behind bars, and that being the only treatment. By 1880, dozens of states had constructed asylums in rural settings, and there's a design proposal of the Shepherd Asylum that's on the screen. It at the time, prisons were incredibly punitive spaces and did not look, have this bucolic, beautiful nature. The asylum itself was thought to be curative. That was how it was created. And at the time, doctors were also using sedative drugs, hydrotherapy, work regimes as their form of treatment for mental health conditions. Families often committed their relatives to institutions when their behaviors made them unable to work, or they carried a risk of violence. And so they removed them from their homes and communities, and people were often sent hours and hours away from their homes. So I know in just as a comparison, in North Carolina, there were North Carolina tip to tip is 8 hours long to drive from one place to another. There were only 3 asylums in North Carolina. And so people in a time of railroads would have to travel huge distances to get to these asylums. That was part of the cure, kind of in a very different mindset of sending people away to get cure. Again, that is that response to people being in jails and poorhouses. In 1880 to 1920, custody was always a part of asylums, but really between these years, it came to the forefront, and there were local and national debates about the nature of asylums. These places often were overcrowded and underfunded, which was a major chronic issue there. By the early 20th century, asylums often served as surrogate homes for people who were elderly or had disabilities, and also people who had chronic mental health conditions. The growth of cities and wage labor during that period of industrialization really made it harder for families, particularly ones from working class and immigrant backgrounds, to care for their family members who could not work. Asylums were often also racially segregated. Either there were separate asylums for African Americans. So in North Carolina, there was a separate asylum for African Americans, which was much less funded and had much worse conditions. And there were also hospitals that had sections that were segregated, as in there's a photograph on the screen from St. Elizabeth's in Washington, D.C. in 1915, which had a ward for African Americans. Another thing to really keep in mind in this period is that eugenics and fears of insanity during this period and its link to criminality really fueled the rise of asylums. I have on the screen a photograph from, it's actually a stage demonstration in New York in 1915, and the sign reads, "Would the prisons and asylums be filled if my kind had no children?" Asylums in that period were, particularly 1880 to 1920 in the eugenics period, were a way of removing people from society for fear-based reasons too. And that fear was a part of this. Because of all this, public asylums often served marginalized people, and they were not receiving enough funding. They often employed very few medical professionals. There might be just a few doctors or alienists at that time or psychiatrists who were in charge of them, even though there were hundreds, if not thousands, of people there. And people housed in asylums often lived in really crowded conditions, worked without pay on farms or in workshops, and experienced violence. These conditions came into the public eye. It wasn't as if this was not known. It came into the public eye, and one example is in the Chicago Tribune. It actually had an article in 1896 about multiple people who were injured and killed in Illinois' asylums. One of them was Julian Grabowski, who was fatally scalded in a hydrotherapy tub in an asylum there. And there really were charges and investigations of, how can we improve the conditions there? How can we give more funding at this time? World War II, in the big scheme of things, is really a turning point in the history of mental hospitals and also prisons. It brought one of the biggest things that happened was that during the Great Depression of the 1930s and then World War II in the 1940s, there was a huge deterioration in the quality of asylums. Like if they had been bad before, they got much, much worse with the lack of funding and attention caused by the Depression and World War II. I brought up a piece of art on the screen, which was by Robert Riggs in 1945, of a psychopathic ward at the Philadelphia State Hospital. Philadelphia State Hospital at this time was about at least 5,000 people, so it's thousands of people large. And the conditions, the lack of funding had led to just terrible conditions in which people were in states of undress, were kept, with dozens of people with only one or two attendants. And in this period, there was a group of conscientious objectors who had been working in them as part of their service, and they ended up really exposing the conditions at mental hospitals, and that really galvanized national outrage and led to a huge amount of reform and helped spur on a move to looking to alternatives to asylums in some form. It took a while, but it was one of the seeds of this period. From the post-World War II period up into the 80s, there were huge developments, as many of you may know, in psychotherapy and the evolution of drug therapies during that period. And it meant that many psychiatrists were increasingly imagining treatment not happening far, far away in an asylum, but instead happening in local communities, because both drug therapies and psychotherapy can be given in people's local communities. There also was that push towards against sending people far away. The National Institute of Mental Health and the American Psychiatric Associations really advocated for new settings that weren't far off asylums as treatment, appropriate for treatment. For me, one thing I really have wanted to bring to the public's attention is that this history, though, is not just driven by doctors, but that people who are self-advocates, politicians, family members across the spectrum really advocated for change. And as we're thinking about how to make change today in our society, really trying to empower a wide array of people, not just experts or doctors, although they're also important here, but really thinking about a multi-pronged approach. Here I brought up two to give an example of what I was talking about. In 1963, John F. Kennedy, who had a sister who had been institutionalized, signed into law the Mental Health Centers Act in 1963, which really was envisioning having a future where there were far fewer large mental hospitals, institutions, and many more community health settings. Another person I highlight in the exhibit is Judy Chamberlain, who really advocated for self-advocacy for people with mental health conditions, really advocating for themselves and having a voice at the table. We engaged too in the limits of community at that period, and that even as mental hospitals were reducing their beds and alternatives arose, many states did not create enough community services to support people. I studied Pennsylvania, and particularly the Mental Health Association of Pennsylvania, and I found in their records just letter after letter to the governor saying, you know, you are reducing numbers of beds in mental hospitals. We need more money for housing. We are not getting nearly enough money for housing, nearly enough money for job supports and other supports for people in their communities. And this is a real issue. And so there were mental health advocates advocating for a different vision that often didn't come to fruition. It often wasn't a priority. I will mention that one thing we have to keep in mind about money is that just as in the 1970s and 80s, many policymakers, politicians were saying we didn't have money, don't have money to pay for these things. Money was going to the building and constructing of prisons throughout the country in the 1970s and 80s. So it was more about where the priorities of money were going. In the exhibit and in the book, I talk about the story of George Elder, and I try to weave stories throughout both of the works that I do, all the work that I do. George Elder had been a conscientious objector during World War II, and he had been institutionalized in large part because of his resistance to the war, his resistance to fighting, and he ended up being institutionalized for 30 years. Even though multiple people over time had argued that he should not be there. In the 1970s, during this period of deinstitutionalization, he was released and he went into Philadelphia, and again, did not have those like quality housing, did not have great community supports at that time, and actually ended up going back for a time to Philadelphia State Hospital. As the number of people in hospitals fell, the number of people in prisons rose. And that gets to what I had mentioned before. This is a chart on a chart on the screen is from Bernard Harcourt, who a number of years ago tracked first, you know, what the rates of mental hospitals were. So the number of people in mental hospitals is this middle line that goes up and reaches its peak in the 1940s and 50s, and then begins a dramatic decline in the 1960s and 70s. Often we associate deinstitutionalization with the 80s, but in fact, it really was dramatically decreasing in the 60s and 70s. The rate of imprisonment, on the other hand, was incredibly low in comparison, or much lower in comparison. And so it actually only starts to rise in 1972, when it starts to increase exponentially, up into 2000s, reaching up, and I'm sorry that it doesn't include it in this graph, goes in fact higher than the rates of all institutionalization and mental hospitals by 2000. This chart really had me thinking about US history, US politics. Many people have looked at this chart and have said that the people who were in prisons just went into mental hospitals. And while there were people who did transfer, called a transinstitutionalization, into prisons, that's not quite the whole story. The bigger story is that in the United States, there had been mental hospitals, and the general public and politicians rejected that form of institutionalization. And then at the same time, we're embracing a new form, which brought in many new demographics, including predominantly African-American and Latino men and women into that, and also predominantly people with mental health conditions. A major factor fueling the rise of prisons and the development of mental health in prisons was fear. In 1981, President Reagan had an assassination attempt on himself, and the person had been found not guilty by reason of insanity. This and also the death of Harvey Milk and these debates really fueled this fear of people with mental health conditions. A big piece of fear also emerges in 1970s and 80s with really racialized drug wars, in which so many African-American communities were targeted for imprisonment. Another thing that develops in the 1970s, 80s, and 90s is the building of psychiatric wards in prisons. This is really a new construct. It had existed over time, but quite small. But in the 1970s, 80s, and 90s was the expansion and the growth of psychiatric wards and hospitals within prisons. And some of those are some of our biggest mental health providers today. That really dates to that period as a response to many more people with mental health and substance abuse conditions going into the prison industrial complex. These developments led to the fact that in prisons, many people who had been diagnosed with serious mental illnesses, both women and men, were much more likely to be people who are incarcerated than in the general population. This is a chart based on the Vera Institute called On Life Support from 2014. So these are not reflecting today's numbers. This exhibit, again, was made in 2017 to 2019. But you really understand, and this is an issue that Mental Health Colorado is working on. It's so important. It really is also a development that's unique to the late 20th and early 21st centuries. Another phenomena that's so important, and I actually don't go into it in the exhibit, but I do in the book, is that actually many mental health institutions across the country converted into prisons. So another thing that drove the rise of imprisonment was that there were a lot of mental hospitals that had closed because of deinstitutionalization, and the states felt that they could more affordably build prisons by converting these big old hospitals into prisons. And this actually, exists, many of them today. They continue to be correctional institutions. Many of them also, like in Pennsylvania, actually have very large mental health providers within them because of their legacy as a mental health institution. And so it's part of that legacy that really drove the asylum legacy, in fact, helped make possible the rise of mass incarceration. The exhibit ends with having people think about and learn about ways that people today are trying to break this cycle. One thing that I try to emphasize is that there are multiple players, multiple stakeholders trying to make change. The change doesn't happen just from one way, just from a politician, a president. Instead, change happens in many different forms. One form that I talk about in the exhibit is that police departments have been conducting trainings and bringing in crisis intervention teams, as in Memphis, to foster better understanding of people with mental health conditions or try to break that cycle of incarcerating people when people are in crisis. Another is that many local governments are creating mental health and drug courts, and many of you, I'm sure, are aware of this, diverting individuals to more community-based treatments rather than confinement. Federal agencies like SAMHSA have been doing research and trying to encourage community-based corrections as an alternative to asylums, to that, lock them up and throw away the key. And that resonates in many ways with that community mental health movement from the 60s and 70s. And then finally, it's so important to really highlight advocates who continue to fight for self-determination and people's rights to their own mental health care, determining that, and protections around involuntary confinement or commitments. Also, advocates are doing work really trying to address the racism in the system, discrimination that people are facing, and that over-criminalization. So that's, my general approach to trying to get people to think about it. And again, many of the audiences that the exhibit is geared towards are people in the public. So this is going to medical schools, universities, libraries, that type of thing, where this topic is often quite new to people. And the idea is educating the public so that they're more aware of this and hopefully more receptive to initiatives like mental health or drug courts, or like anti-discrimination efforts, or crisis intervention teams, community corrections, trying to get public buy-in. I was then opening it up for discussions because, as I said, I really see this as me sharing and then opening it for discussion to learn from all of you, and we can learn from each other. I just had 3 requests, which is if you're able to just be respectful. We're all coming from different perspectives. I'm trying to actively listen to others' ideas, and then just being mindful of our time, making sure we're giving people time to ask questions and comment. But again, thank you for having me.
So we'd like to invite folks to chime in with thoughts, questions, come off mute. See.
And feel free to place any comments in the chat. I guess, Michaela, if you're able to also read them out, that would be wonderful. Thank you.
Estrella, you're welcome. Yeah.
Okay, thank you. So I live in California. We've had a series of recent laws that have been passed that seem to be designed to well, address the mental health needs of people with mental health issues, but at the same time they seem to also be taking away rights in a way that is definitely concerning. And I was wondering, I'm also very aware, apologies to anyone that's present, but I'm also aware of the strong drive by certain organizations that are made up of family members and so forth towards encouraging laws being passed that what's the word? That make treatment mandatory. I guess that's how to put it. I'm not saying it very well. But so what I'm asking is, what are some other alternative options, but besides prison, asylums, being out in the streets and so forth, for people who are struggling and may or may not know how to get help?
Hmm. This is where I'll briefly respond and then with a story and then open it up, because this is where I do find that I'm a person who's thinking about this, but I'm often in the past, and there are people very much working on present issues that can jump in and perhaps can talk about what's happening today. The story I'll tell is from the 1980s. In the 1980s, well, as I said before, in the 1960s and 70s, there were many people who had been in Philadelphia who had been released to the streets, and there were many people who were concerned, like as you're describing, that we needed to give better care for individuals, and that there was also a fear-driven need for, like, we should be trying to either lock people up or having involuntary commitments, etc. And there's a really powerful story at the Philadelphia State Hospital at Byberry by the 1980s. By that point, the Mental Health Association of Southeastern PA had developed a really strong self-advocacy group, many people who themselves had been former patients, and they worked with lawyers and policymakers around the issue of closing this hospital and what would happen to the people there. And they ended up being able to really advocate for funding for those individuals. Lawsuits were involved, which often helped bring out money. But they were able to advocate for the city to really invest in people's housing needs, access to medical care and mental health care, and issues of employment, people having making sure that every single person had individualized care, and then also being able to track people and over time, if that makes sense. That is not saying that that solution is what should happen today, but I think that that process of having self-advocates working in partnership with medical professionals, policymakers, and also getting the resources to make things happen. Do you know what I mean? To be addressing, for instance, homelessness, to be addressing medical care, access to mental health care, that type of thing, are key ingredients that I learned from that story in Philadelphia, and I'm often not seeing, at least in the state where I'm living. That said, I do want to open it up to see if others have any responses to Australia's question.
One quick thing.
Yeah.
I just want you to know that your book is the next book I'm
Oh,
buying.
good. Yeah, wonderful. Yeah, I'll take it. That's
All right, I'll
wonderful.
put it.
Yeah. Just hearing if anyone in the room, has thoughts on this today from a more contemporary perspective.
So I'm Kane. I'm a co-response therapist. Strella, I would say for some of those supports, they're going to be really community specific. So it's going to depend on what's specifically in your area. I work in Southwest Colorado, and oftentimes if we do have to put someone on a mental health hold, they're oftentimes not staying in the area and they have to go to the Front Range because we don't have hospitals, right? And so for a more but a lot of that is fronted through our community health organization that works in tandem with another nonprofit in town that focuses on things like housing and food and Medicaid and helping people complete like government enrollment forms and all of those pieces. And so I would look specifically into your community, even if you have like a local crisis line, that's a good place to start, just giving them a call and being like, hey, I'm looking for some supports. It sounded like you were talking about a conservatorship or forced treatment at one point in regards to substance use, or potentially in regards to like long-term mental health supports. That's often through the courts. And so that's going to be your best support. Likely going through your county court, but potentially your municipal one. I don't know where you are, so I'm sorry. But those would kind of be areas where I would start, or if you have a community mental health agency, check and see if what kind of services they provide. Like ours provides dental care, primary care, as well as mental health care and substance use treatment. And so it kind of just depends on what your space supports.
So I'm Elizabeth. I'll kind of weigh in here and make a comment as well. I'm also in the co-response world. And what I see in my work is that it seems like that emergency level mental health hold and or some criminal component that then also results in arrest is the place that people start with getting access to care. And that's a problem, right? I don't know the cause of that. I could speculate, right? I think some of it is about stigma, where early interventions aren't effective because of the stigma associated with mental health. And then the other thing I think I would name is that it's lack of resources, lack of services in place, lack of ability to access that care, right? Like navigating access to care is a huge portion of what I do when I come in contact with people, and really trying to get them into those community mental health centers and get them at that early intervention place so that their treatment is in line and it doesn't have to result in institutionalization or even a mental health hold, right? Mm-hmm. Like that's there for a good reason, those holds and that statute, it's very important and valuable. And how can we use it less, right?
Yeah.
So just my 2 cents.
Yeah, and that's my concern is what are we doing to create alternative, alternative options for people who are struggling so that they don't end up getting caught up in the criminal justice system, and I know there are certain things, but I just want to it doesn't get addressed enough except from the perspective of involuntary treatment. And that's what concerns me.
Mm-hmm.
I think if I can chime in for a moment, one of the things you said earlier resonated for me, which is that often the folks who are vocal in these spaces in terms of advocacy and, getting bills passed and all that kind of stuff that shapes our care system are the family members, and they are not the ones that have the direct experience of these systems. They might have an indirect experience of those systems through supporting a family member, but is frankly not the same. And so how can we sort of, I think there's an element of stigma that plays into why are folks with mental illness not at the table for these discussions? And I think that might be an important thing for us to consider in building that, building the services and things that you're hoping to see.
Definitely. I'll add on as well. My name's Linnea. I'm coming from New York City. Michaela and I were actually recently at a convening where I think like in this issue area, and I think a panelist said something that is really like occurring to me, at least in this moment, is that right now a lot of our solutions to some of these problems really lack any feeling of community care. And I think if we're going to be envisioning a world where we're not seeing measures like this in California or things like that, I think we really have to like get creative and think through what it would really look like for each community to have their own system of care. So kind of to what Kane was saying earlier, like it is super bespoke to like each community and how they work. But I think making sure that people like with lived experience that are going through crises like this feel as though whatever response is coming to them is just like with like a warm touch.
I mean, this is where I think that's so powerful. In a lot of ways, that's what inspired me from that Philadelphia example, where it was just like really thinking through, you know, what a community of individuals needed, a small group of individuals trying to then work out. I'm wondering, considering that it needs resources and buy-in from people, I'm wondering a question of, you know, having heard some of this history of how change happens, I'm wondering people's thoughts on how to really get this more in the forefront of getting our communities more invested. Does that make sense? Like into community care and providing it, like what could help make change? Particularly, frankly, in a time of, I think there's quite a bit of conservatism now. I was doing this work under Obama, in which there was a huge move towards decarceration, and that is much more complicated, you know, has been complicated since the Trump years, certainly now. Yeah, but any just thoughts on what you've seen working for trying to get the message out or get communities and societies to change?
Hi, my name is Diane Holton. I have a son that has very severe mental illness, and he's not able to go to like an outpatient program or anything like that. Currently, he's in the state hospital at Pueblo, but he's been incarcerated. In the last 15 years, he's spent 6 years of his life in jail. And he's been very sick every time that he's been in jail with, you know, his mental illness. He also has substance abuse problems too. But what we have found really helpful is the Arapahoe County Jail now has a mental health court. And we've gone to every hearing he has every month. And it's very nice because they address us like we're people, and almost everybody that goes through that mental health court gets placed into a program out in the community. Unfortunately, our son is too sick to go into one of those programs. So as of now, there is no place for him to go. He needs a locked long-term environment. And so today I've spent all day calling places, and because of his substance abuse, they want to send him to a nursing home. But he's not safe in a nursing home with elderly patients because he has a history of violence as well. And but the mental health court has been absolutely amazing. I can't say enough good about the mental health court at Arapahoe County, and Judge Volz is amazing. That whole court is amazing. They've really helped us, and we have somebody who contacts us and keeps us updated with everything. And so that's been very, very good. That's a new change that has been just so helpful for us. So,
Yeah, thank you.
I don't know if anybody has any ideas of a long-term placement program. If you have any ideas, I'd love to know of any places. So thank you.
I think in part what is missing, and what I'm hearing in your story, Diane, is, you know, that they're not necessarily the systems of care for what people need. That there are gaps in our systems.
There are, and my son, I don't know that he'll ever be able to come out of an institution, but right now there is just not any place for him to go. He's 33, and the thought of putting him into a nursing home, that's very sad for me. I can't even go there right now, but anyway, that's all I had to say. I think the mental health court is doing as much as they can for those people that are able to go to programs in the community. It seems like almost everybody we've seen has been placed in a program out in the community. So I think they're doing a lot of good in Arapahoe County with the mental health court. So that's all I had to say. Thank you.
The it sounds like that shift in having courts that are sensitive, that are really focused on mental health, has impacted you as family members, or supports certainly. As how has your son experienced it? Any different, or not much sense? Or
As far as my son, we really haven't talked to him very much in the last year, and he won't come to the phone now in Pueblo. So we call every day and see how he's doing, but he just sleeps pretty much all day long. He's not, he's in a really bad place. He's not doing well at all right now. So, but going to jail all those times definitely made him so much worse. He had his hand crushed by a deputy one time. All the bones were sticking out of his hands. He's had seizures in the jail. He has a traumatic brain injury. He's been beaten so many times in the jail. He was placed in isolation for 8 months, which he didn't talk, or I mean, we could not interact with him for over a year after that. But the jails have been horrible. I mean, I can't say enough about the bad things that have happened to him in the jail, and I think it set him back so far, so far. Every time he's incarcerated, he gets so much worse, so much worse. And we're not able to talk to him, have contact with him while he's in the jail. We're fortunate enough to have a liaison that works with us, which is wonderful. That's been really good. And she's just a liaison with the court, so she keeps us updated. And this last week, we were able to meet actually with the mental health court an hour before the hearings started and just sit and talk with them. So that was really good too. So they're wonderful. I just can't say enough.
yeah.
So thank you.
Yeah, no, thank you for sharing your story,
Yeah.
particularly here. And
Yeah.
I really hope, one basic thing is, unfortunately, way too many, if not all, of our prisons and jails, like, often are sites of violence and trauma unto themselves. And so kind of a separate issue from just how are people accessing care is, how to prevent trauma and abuse in the jail and prison system, and really looking at alternatives to prisons. Do you know what I mean? And alternatives to criminalization. And that is where it sounds like the mental health court is helping around that diversion. And one thing if I will say is that throughout the history that I've seen, many people, both who themselves were patients and also family members who were have shared their voice to try to argue for things that are more helpful. And I do think that this is where mental health courts or diversion programs out of jails and prisons, alternatives to jails and prisons and decarceration, is important. And I think your story could be really powerful with policymakers or politicians to keep spreading it.
Okay. Thank you. Thank you.
Think about. Yeah.
Thank you.
I was seeing in some of the chat that there was someone had mentioned that they themselves were in 1980 was invited to create options to remove people with mental health conditions from county-run jails. And this really was in the 80s. There was this real movement to decarcerate prisons too, but it really did not succeed. And so those jails became that first response thing. And so trying to build a different world. Bridget also said that that there's a lack of streamlined support along the continuum of care. And so really trying to think about ways to streamline this. Thank you for bringing that. From the histories that people have heard, were there other questions that bubbled to the surface, reflections, comments, thoughts?
Hi, my name is Jonna, everyone. I am a graduate student for social work, and I'm actually am working on somewhat of a project within policy and kind of the very beginning steps of how you can create policy and push it. And so even just hearing Diane, your story, you can pretty easily find your local like rep in your county for local government and reach out to them. They're your constituents. They're supposed to hear from you. And they want to hear from you. And so if you bring up your concerns and give your story and give that passion, they can move it along into, you know, specific legislators and even, you know, create bills and policies off of it. But it can start as small as just like a phone call or email being like, you're my local rep and I have some issues and concerns about X, Y, and Z, and try to schedule a meeting with them. I've done that. I had to do that for this project, and you definitely have to work hard at getting them to respond to you, but they will. And then it's just having that conversation and really just moving people with stories. It's like we're all human beings. So if you're able to push that story in a narrative that's like for you and for many other people, that's kind of how at least I've been learning that things can make change. It's obviously not as easy and simple as that, but it's definitely a place that you can start if you want to do that.
Yeah. Thank you for that. Like, think about the nuts and bolts, because there are so many people who are like, how do I actually,
Yeah.
find people or make change? And I'll just add on that it also can be helpful for people to hear about what's going well. So even Diane, like the fact that you're having this, like, in your case, that diversion and the support of mental health courts contacting any local politicians or representatives or council people that about the need for that is helpful, in part because these things that can be created can also be taken away. I did, if that makes sense, I had done a lot of work in Louisiana around decarceration efforts with youth in prisons. And there was a lot of efforts around trying to affect rates of incarceration. And I just learned in Louisiana, and I just learned that the new governor in Louisiana just effectively ended, I think it is early parole completely. And so people have to serve out their entire sentences immediately. And that was something that advocates had just worked on and worked, like worked around trying to find alternatives year after year. And then a new governor comes in. And so I will say that by helping to establish some relationships around what does work, and then, helps you, if the mental health courts have been important, or those diversions, do you know what I mean? It's important that people are hearing that. It's important that you're getting that practice so that if those things come up for cuts, do you know what I mean? Like if there, is some incident, because I'm just very aware as a historian, as a person, as an advocate, that what is created can be undone. And it's important to try to protect things that are powerful. Oh, we'll see. Oh, it's already 8 o'clock. I was like, oh my God, I apologize. I was like, oh, okay. Like we have a while longer. That went really fast. I'm sorry. I lost track. I was just immersed with all of you. If anyone has any questions or wants to stay after, feel free to stay on the Zoom if that's okay, Michaela. But truly, thank you all for being here. I hope there were some ideas or synapses firing from some of the history of what's happened in the past and thinking about this in a bigger picture. So thank you for coming tonight.
Thank you.
And I just want to quickly thank you, Anne, for a wonderful presentation and for guiding us in discussion this evening. And also just want to remind folks that we will have another webinar on June 20th focused on Albuquerque Community Safety Department and their very thorough alternative response model. So if you're interested in, I guess we've kind of landed in a very similar.
Yeah, no, I'm like, okay, that's
yeah, please
phenomenal.
join
Yeah.
us in June for that. And thank you all. Yeah, please.